is the director of the electrophysiology department and the deputy director of the cardiology department in Qasimi Hospital in Sharjah. As you know, he's very, very active in academic pathway as well, and he is the director of the Gulf Live EP transmission that some of you may attend on regular basis. He's going to talk to us on atrial fibrillation and diabetes with renal preservation perspective. Dr. Muhammad, please.
Thank you, Dr. Nasheen, so much for the nice introduction. I hope
Dr. Muhammad, you are muted, I think.
I think you can hear me, right? Can you hear me, Dr. Nasheen?
Yes, Dr. Muhammad.
Okay, because I already unmuted myself. Can you hear me, guys?
Yes.
Okay, perfect. So thank you, Dr. Nasheen, for the introduction. Thank you, Bayer, for the invitation. And I hope today we will reach a consensus about the approach for non-valvular AFib management, because when we have a simple case coming to our clinic with non-valvular AFib with very few comorbidities, I don't think this is the biggest challenge. The biggest challenge when we face a case with multiple comorbidities regarding the age, diabetes, renal function, hypertension. So unfortunately, this is mostly our patient here in the region of the Middle East. Like I'm gonna show you now, just I would share my screen. So today I'm gonna share with you some of the updates regarding the NOACs, and I will share one of the case approach scenarios to one of our patients, and it's very common case scenario that we face every day, almost on a regular basis. Yeah, as you know, we have 4 cath labs in our hospital 24/7. So every day we are admitting patients with acute coronary syndromes, abnormal renal functions, diabetic patients with different types of arrhythmias. So every day we have this meeting in the morning, and it's not uncommon to have one difficult case to discuss how we will manage the anticoagulation, antiplatelet management for such patients. These are my disclosures. I always like to start with this because actually this publication is from our region. So instead of just speaking about the risk in Europe or in the US, this study, the Gulf SAFE, that I'm sure most of you know about this trial, which is very impressive, covering over 2,000 patients with non-valvular AFib. And when you look in our region, the age is not like in Europe. In Europe, when they put the Schatz VASC score and they discussed cases of AFib, they speak about elderly patient above 65. Our patient characteristics in the Middle East and in the Gulf, it's a little bit more unique, I can say, because we have younger patients, as you can see. The age is around 57. 30% they suffer coronary artery disease. 30% of them, they were diabetic patients. Almost 10% they had prior strokes, and more than 30% they had persistent AFib. So you can see from the characteristics and demography of our region that we are not facing a simple non-valvular AFib cases on daily basis. Actually, we have more comorbid patients, and unfortunately, and this is heartbreaking as well, that our patients, they are at least 10 years younger than the patients seen in Europe. When I was doing my fellowship in France, it's quite rare to see a patient with non-valvular atrial fibrillation with such comorbidities at age of 60 or 50. This is quite rare. But here it is very common that you can see a patient 50-year-old with such multiple comorbidities. We were fortunate to live nowadays in the era of NOACs because during our early years of training, we didn't have anything beside warfarin. And of course, as you know, we had lots of problems with warfarin, but it was the only medication available to prevent strokes. But me, myself, I can recall during my residency on weekly basis, we have one case at least of major bleeding, whether cerebral bleeding or GI bleeding, with warfarin. And the question was, after this bleeding, how are we going to manage this case? Because if we're going to resume the warfarin again, the patient might have another bleed. So it was a serious consequences. And thank God now with the NOACs that we are having since 2009 and onwards, they are providing us, let's say, effective, in addition to secure environment to protect our patients. And what's nice, when you look at the characteristics of the major trials that was done, we have a nice mix. We have a mixture of some of the studies, like having different risk groups, like you can see in the Relay and Aristotle, and you have something like the Rocket AFib with Rivaroxaban, having a more complex, more cases with multiple comorbidities. You can see 87%, they had a SHAD score 3 to 6. And this is quite high SHAD VASC score for such a study. So this is very nice mix, so we can have an idea about the different groups of NOACs that we are using and how we can utilize them to prevent stroke in an effective way, in addition, in a safe way to our patients. And I think everyone is familiar with this slide, that I think we are not questioning anymore the NOACs, that they are very effective in preventing embolic events in comparison to warfarin. In addition, they are more safe in comparison to warfarin in preventing not only ischemic stroke, but hemorrhagic stroke and all-cause mortality. This was my introduction for today's presentation, but let's start with this one of the complex cases that we usually discuss in the morning meetings every day. So we have our patient. He's a 69-year-old patient. He had AFib 3 years ago. He is diabetic patient on medication, and he has eye problem. He has diabetic retinopathy as a consequence from the diabetes, and uncontrolled hypertension. Most of the time his blood pressure is 160/100. He's managed by beta blockers and diuretics. His SHAD VASC score is 3, so his annual risk of stroke is almost 5%. And don't ask me why this patient was on warfarin when he was referred. I'm not sure 100% why he was started on warfarin, but when the patient presented to us, he presented with something else. He came not because of the AFib, he came because of exertion angina, unstable angina. And he was at that time on calcium channel blocker, and still he had repeated attacks of chest pain. So angio was taken by our intervention colleagues, and it showed an ST lesion, 85% lesion, stenosis in the LAD, and no other lesion. During assessment, the patient had moderate renal impairment. So his creatinine clearance was 46 milliliter per minute. So if we look at this patient in deep analysis, our patient is diabetic with complication, started to have diabetic retinopathy. He has renal impairment, which is a major sign of diabetes, as well diabetic nephropathy, uncontrolled blood pressure, and he underwent recent coronary stent. In our hospital, this is from the data from our hospital, more than 30% of our patients, elderly patients, they are diabetic. And more than half of them, they have diabetic nephropathy. And guess what? You can say at least 25% of them, they will go through the experience of dialysis. So this is a major problem that we are facing. This is a very tough case, and the usual question will be raised in the morning meeting, how we will manage this case. First question will be how we will combine the anticoagulation with the NOAC, and whether to choose which type of NOAC, and the antiplatelet with NOAC, which is tragedy, triple therapy or dual therapy. And I know this is a very hectic question because everyone, of course, is fearing bleeding, and at the same time, we don't want any complication, but not to be on the expense of prevention of stroke for our patient. So when you look at this, which regimen you would like to choose? Would you like to choose warfarin with aspirin, warfarin with clopidogrel, or triple therapy, warfarin, aspirin, and clopidogrel, aspirin, clopidogrel, or NOAC? You have lots of options, lots of variables, but I hope after my introduction, at least the first three options will be out of mind. No one will choose warfarin for our patient, because we already know warfarin can cause a major bleeding problem without an ideal protection. Just imagine if we combine this with even single or dual antiplatelet therapy. But let's answer this question at the end after we go more into depth about the recommendation and the guidelines and our case. So as we always say, every patient is a unique puzzle, and you just try to have the input of the data from the patient criteria and the patient characteristics and combine this to the studies that's done, either real world data or the guidelines, and try to come with a solution to prevent stroke and at the same time to avoid complication. So when you look at the guidelines, it's clear in the guidelines that NOACs are recommended in preference to vitamin K antagonists. So I don't think this would be a question to be raised anymore. So getting this out of hand, we depend 100% on the shared VASC score. So if we have men more than 2 and more or equal than 3 in women, we have to prescribe anticoagulation for our patients. The next step, which is very important, especially if you have a high-risk case, we have to calculate the HAS-BLED score, which is already approved in the guidelines. Especially in the HAS-BLED scores, you have modifiable factors and you have non-modifiable factors, and those modifiable factors, we have to keep close eye on them. So it's not just simply to give the patient the medication and we feel secure today that everything will run well. We have to bring the patient back according to the risk, maybe every 3 months, maybe every 6 months, to follow up on the patient, because the factors might change. The patient is a dynamic process. It's not a static process. So this means once we start the medication, we have to apply close monitoring for our patients. When you look at this HAS-BLED score, let's review our patient. He's hypertensive, that's 1. He has abnormal renal function, that's 2. He has labile INR, that's 3. He's more than 65, that's 4. He's taking antiplatelets, that's 5. So our patient HAS-BLED score is 5, which means his risk of bleeding is 12.5%. And this is quite high. And I think everyone listening to me agree with me that this patient is a very high risk for bleeding, as a high risk for stroke. So we have a very difficult question to answer and a dilemma now that this patient is high risk of stroke, high risk of bleeding, how we will manage this patient, how we can approach. Again, as I mentioned, we have modifiable risk. That's why we need to keep an eye on the patient renal function. So like for the patient that I just presented, I will like too much to bring him every 3 to 6 months, maximum 6 months, preferably every 3 months, to do renal function for him, CBC for him, monitor his body weight, because you know geriatrics as well, the nutrition for them is very variable, and if the body weight is affected or renal function or hemoglobin, this might affect our management for such patient. And of course, creatinine clearance is very crucial, because this can differentiate from one NOAC to another according to the renal excretion, as I'm going to show you later on. So when you look at this in the guidelines, our patient will fall in the column in the middle. This is elective PCI for our patients, and we are fearing thromboembolic manifestation for our case. And this column, if we look more deeper inside the analysis, we have a concern. I think everyone agree that we have a concern about the bleeding because of the high HAS-BLED score of 5. So when you look at this patient, either I think you will go with column in the middle, this one, or the third column. For me, when I have a HAS-BLED score of 5, this is a major risk for bleeding. I will go for dual therapy. So our patient, we will start with NOAC and clopidogrel P2Y12 inhibitor for 12 months. Then we can carry with only NOAC. So the guidelines is paving the road for us from the studies and the trial, aiming at improving the patient safety, not on the expense of complications. So I hope everyone agree with me that at least now, for the time being, we agree that the patient should start on NOAC with P2Y12 inhibitor for 12 months because he has a high risk for bleeding. We have several studies addressing such topic, like the Pioneer study for Rivaroxaban. We have the Renal for the Bigatran, and we have the Augustus trial for Apixaban. And all of them, they agreed, and it's mentioned clearly in the guidelines for the time being for the Pioneer and the Renal trial, then those patients that I just mentioned with such criteria, it's better and ideal and safe for them to give them either Riva or the Bigatran plus P2Y12 inhibitor without aspirin, without rapid therapy, because this increase more the risk of bleeding for such patients. So the question, which NOAC? I know this question is very difficult. All NOACs, they are good. If you have a simple case with no major comorbidities, mostly any one of them will do the job, will do the trick, but still some NOACs, they are unique in special cases, case by case. So some cases, especially the high risk patient, you have to go more into depth into the studies and the NOACs to choose which the proper NOAC for your patient. Our patient is a very complex, as you can see. He has multiple risk factors. AFib, as AFib, he has 5-fold increased risk of stroke. He's diabetic patients, which increase the risk on the kidney and the risk of stroke as well. And the kidney by itself, it can progress more and more depending on the stage. If he had moderate renal impairment, stage 3 or 4, it can progress even to stage 5. And also this increases the risk of stroke. So you can see also all of this creating a vicious circle for our patient and can lead either to serious consequences in the form of renal failure or cerebrovascular events, which of course it's major. Protection from the cardiovascular death in patients with non-valvular attack and diabetes, it was proven in NOACs, they are very effective compared to warfarin in such group of patients. So it's very effective, especially in diabetic patients. When you look more into depth with Riva and the Rocket AFib trial, just imagine, as I mentioned earlier, the SHATS-VASc score was quite high. Not only on the expense of high SHATS-VASc score, 40% of the patients, they were diabetic patients with the mean SHATS-VASc score almost around 4. This is quite impressive, especially for diabetic patients, especially for our region. So when you look into depth about the analysis, you will find that comparing to warfarin, Riva was very highly effective in protecting diabetic patients from the major bleeds and the vascular death events. I just want to mention something. This is good for diabetic patients with high risk non-valvular AFib, but keep in mind, if you have a patient with history of GI bleeding, you have to consider this is in the history of the patient. If the patient has a GI bleeds or history of GI bleeds, you have to think which the proper NOAC to prescribe for this type of patient. Another study regarding the effectiveness and safety, again, for Riva versus warfarin. And here we are looking at the major cardiac events and limb amputation. And this study was carried for observation for 5 years. And look at this again, it's favoring Riva versus warfarin regarding ischemic stroke, myocardial infarction, and major limb amputation. So I think we don't have any doubt now when you have a patient with non-valvular AFib and diabetes that NOAC, especially Riva, because of the trial was conducted in a such way to include 40% of diabetic patients with a high SHATS-VASc score, it's very effective compared to warfarin with high safety and less major cardiac events. This was combined as well with less major bleeding and intracranial bleed. And again, as I mentioned, when you have a GIT bleeding, you have just to focus on this entity when you prescribe the NOAC for your patient, because this is very critical, very crucial. I will tell you from my experience, when I have a patient giving repeated history of gastrointestinal bleeding, and this patient is elderly, let's say if our patient that I just presented to you, he had repeated GI bleeds. If this history is on board, I will be totally honest with you, I will not give him NOACs, I will not give him anticoagulation, I will offer him appendage occlusion for this patient, if he's feasible for appendage occlusion. Because if you have a repeated history of GIT bleeding, I believe all of the NOACs, putting the patient, or of course the warfarin as well, I'm just saying warfarin is out of the question, but if any NOAC you will give for the patient, it was history of repeated GI bleed, the patient is a potential risk for GI bleed. So I will offer him left atrial appendage occlusion, but please keep in mind, this is not a common history and common scenario. Our hospital is one of the main hospitals doing left atrial appendage occlusion, and we are doing around 12 per year, average once per month. So this is not a common association, but I just raised the issue because it's a very important when you face such problem that you know that there is another alternative that you can provide for our patient. So the biggest challenge here, which is very dynamic, is the renal problem as well. Because as I mentioned, it's a vicious circle, it's a dynamic circle. Most diabetic patients, especially uncontrolled diabetic patients, the disease is progressive. It's not uncommon to see a patient like coming to the clinic 1 year ago with stage 3. After 1 year, he already passed to stage 5. So what we are looking at, we want to give a medication. I will not say only like a nephroprotective medication. We want to give a medication that cannot lead to progression of the renal disease, which is very important. And as you all know, there is an amount of renal excretion for different types of NOAC. The least will be the apixaban and the Rivaroxaban that we are having now in the UAE market, was around 25 to 30%. So you have less renal excretion. So when you choose a NOAC for our patient, and the patient has moderate to severe renal impairment, I think the Rivaroxaban will be out of the question for this patient because of the 80% mainly renal excretion, especially that we are going to give him antiplatelet therapy for the recent stent. So now we will remain with more safe, less renal excretion medication as an option for our patient. From the Rocket AFib, we have a consistent safety outcome in non-valvular AFib with moderate renal impairment. And not only that, we have less fatal bleeding in comparison to warfarin. And this is one of the trials which is very impressive, to be honest, comparing the NOAC on the progressive of the disease, whether the patient might have any decline in the GFR or doubling the serum creatinine or suffering from acute renal injury. And guess what? All is favoring the NOAC. So the patient is at less risk, reducing the risk by giving NOAC to such patient for the progression of the disease. And when you look at the real world data, comparing all the NOACs as well in maintaining the renal function of such patients, again, it's all of them favoring the NOACs in comparison with the warfarin. And this is a trial, the Caliber trial is very nice, a very unique trial as well, because over 5 years, patients were observed whether they are on warfarin or taking Rivaroxaban, and advanced grading of renal dysfunction, stage 3 and stage 4, and they were observed about the progression of the renal affection and the renal disease. And again, results with the Riva was very impressive. Non-valvular AFib and grade 3 and grade 4 favoring Rivaroxaban, much more protection on the kidney. And guess what? You have more protection in the kidney if the patient as well is diabetic. And this proves the point, when you have a diabetic patient, it gives an advantage to have a NOAC instead of warfarin. And in addition, we have more data with Riva because of the Rocket AFib trial with the 40% diabetic patients, our experience from the Rocket AFib trial. Inappropriate dosing, it's a major problem, ladies and gentlemen. It's a major problem worldwide, and here even in the UAE, it's a major problem. We have lots of patients sometimes coming to us and they are not taking the appropriate dose of anticoagulation. Mainly, I believe it's due to fear and according to the type of the dose of the drug. I will give you an example, especially with apixaban, because you know there is 2.5 and 5 milligram. So some of the physicians, they tend to give the 2.5 in order to give anticoagulation, but at the same time to avoid any possible bleeding risk. But this is a major problem because actually we are not providing protection for our patient. And guess what? Even with the 2.5, if the patient will bleed, he might have bleeding as well. So we are putting the patient just at risk without protection. So this is a major problem, especially with apixaban is very common, I think, because of the dose of the 2.5 dose. Adherence, it's very important for our patients to explain the medication, the importance of taking the medication, especially if it's 2 tablets per day. We have to review our patient medication, the number of the medication the patient is taking per day. One of the advantages of the Riva, it's once daily medication. It's not 2 tablets daily, but on the same hand, the other medication, if the patient is sticking to them, it depends on the patient coming to your clinic. You can say I risk certify the patients when they come to the clinic. If I have a patient who's well educated, well anxious, and he's like coming to my clinic and he has, you know, this small tray boxes and he's very well organized, it will not make any difference if you give him once per day or twice per day. But some patients, especially the elderly, if no one is taking care of them, or maybe someone is taking care of them, but they have like 9, 10 medications, sometimes it helps to reduce the number of tablets that you are giving to your patient per day in order to have better adherence and better compliance. So going back for our patients, is diabetic with complication like diabetic renal impairment, diabetic retinopathy, and hypertension. For this patient, we would choose for him dual therapy. So we will start for him NOAC with clopidogrel for 1 year, then we can carry on with the NOAC. And for our case today that I'm just describing, this will be an ideal case for the Riva, especially this patient has diabetic retinopathy. And someone will say, why you will not put apixaban for this patient? For 2 reasons. From the trials of the rocket showing the results with diabetic patients with Riva was very impressive. Plus this patient, he suffered diabetic retinopathy, and you know, for the molecules, it's something unique. No one knows actually why this is happening, but some molecules, they have tendency for bleeding at certain sites. Like if you have some bleeding incidents can happen in the GIT with the bigatran or Riva. On the other hand, you have bleeding with apixaban in the eye. No one knows why this preference happening, but if I have a patient with diabetic retinopathy, I will not recommend apixaban for this patient because he will have higher incidence of eye bleeds. So when you look at all of this for this case, as I mentioned earlier, all the NOACs, this variation is very good. I believe it's very healthy that you have different options according to the number of patients that you are seeing. So instead of just sticking with one NOAC, you have 3, 4 NOACs that you can choose from. And for the time being, we have only 3 NOACs available in the UAE. So this is very good, this mix. But the only thing that we need to educate ourselves more to know all the studies and how to choose the best NOAC for our patients. To conclude this case, and feel free at the end that if you have any interesting case, we can discuss during the discussion, panel discussion. If you have any difficult case for anticoagulation management, because we learn from each other how to manage such patients. And I would like to tell you with our recommendation and our plan of management, over the last 4 years, we didn't have any, alhamdulillah, any major complication from the NOACs that we are using. In addition, we are not prescribing warfarin except if the patient, for example, has a valve, prosthetic valve, or valvular AFib. And 2 days ago, there were a publication in the JAC, I'm not sure that everyone saw it, about the Rivaroxaban in valvular AFib in patient with bioprosthesis, and the recommendation that I think it was more than 1,000 cases, and it was a randomized controlled trial, and the result was very impressive for bioprosthetic valves with valvular AFib. So I think with the technology, with the improvement, with the research, with the results, I think we will have more and more achievements for our patients, providing efficacy and safety. And by that, I would like to thank everyone for your attention, and we can take the question according to Dr. Nasheen, either now or after Dr. Joseph present his presentation. Thank you, everyone.
Thank you very much, Dr. Mohammed. As usual, very elegant and precise presentation on the topic. Once again, I would like to welcome our colleagues that I can see more and more are joining the webinar from UAE, from Gulf countries, and from regional countries as well. This is a live webinar from UAE. We have two of our colleagues, two senior consultant cardiologists from UAE who are talking about atrial fibrillation and special cases when you treat atrial fibrillation and you treat them with NOAC and specifically with Rivaroxaban. The next speaker is Dr. Joseph Korean. He is also a senior consultant practicing in Abu Dhabi. He's the head of the cardiology department at LLH Hospital in Abu Dhabi. And he's going to talk to us about atrial fibrillation and high-risk patients with atrial fibrillations, patients who are at extreme age and patients who have renal impairment. Both presentations are base case presentations simply because we have passed the stage of convincing you and ourselves for the prescription of the NOAC and Rivaroxaban in the management of atrial fibrillation. We have reached to a stage that we know this is the best therapy that you can offer your patients. But we want to make sure that even the high-risk patients also can get benefit from this treatment. So I invite all of you for active participation in the last half an hour of tonight's webinar, sharing with us your experience, telling us about your questions and your answers. And over two experts, consultants, cardiologists, over two expert speakers will try their best to make everything more clear for a better management of patients with atrial fibrillation. Dr. Joseph, the microphone is yours.
Good evening, friends. Thanks for the kind words of introduction. Thanks for inviting me for this program. We have already heard an elegant presentation on the high-risk patients with atrial fibrillation, which is patients with diabetes and atrial fibrillation. We will see yet another group of high-risk patients who are the elderly and with renal disease. We know that the elderly, as age advances, the risk of stroke increases significantly, so is the bleeding. That holds true for renal disease also. Both stroke and bleeding increases as the renal function declines. Yeah, we'll see a case, Mr. Amin, 76 years old. He has atrial fibrillation, he has diabetes, he has moderate renal impairment, his eGFR is 46. And he has a concern that his friend had a stroke and he needs a caretaker each day. He ended up in dialysis. So Mr. Amin wants to know, is there a way he can prevent a stroke for himself? And anyway, somebody can help him out to prevent the progression of the renal disease or decrease the progression of renal disease. As far as stroke prevention in AF is concerned, it had been really a success story. Even our good old friend Warfarin was able to decrease stroke by almost 70%. Any drug which is able to decrease a clinical event by 70% is considered to be a great success. And for that matter, all NOACs, all the four available in the market today, even Rivaroxaban, we are going to have it soon, all are at least as effective as Warfarin in preventing stroke. Some of them are shade better. And as far as safety is concerned, all the NOACs are better than Warfarin in decreasing intracerebral hemorrhage. And the major bleeding, some of them are a shade better. So if we say NOAC is as good as Warfarin, that means that also decreases stroke by 70%. And if the NOAC is superior to Warfarin, that means that particular drug is going to decrease stroke by more than 70%. And Warfarin, the meta-analysis was able to decrease mortality by 25%. And the meta-analysis of NOAC versus Warfarin, NOACs decrease mortality by another 10% compared to Warfarin. We know that the risk of stroke significantly increase as the age increases. In people between the age of 50 to 59 years, the risk of stroke is around 1%, 1.5%. In 70 to 79 years, the risk comes to almost 10%. The stroke associated with atrial fibrillation has a significantly higher mortality rate. The risk of death is twofold higher in stroke related to atrial fibrillation compared to those stroke in patients without atrial fibrillation. And the severe disability is also twofold higher. AF is associated with a fivefold increase in the risk of stroke. Diabetes is associated with a twofold increase in the risk of stroke. And in CKD patients, there's a 30 to 60% increase in the risk of stroke. So if the patient has AF, diabetes, and CKD, they really fall into a high risk category. The Rocket AF study, unlike the other outcome trials, had a very high proportion of elderly population. The average chart score in the Rocket AF study was 3.5. Nearly half of the patients were over the age of 75 years. And 21% of the patients had moderate renal impairment, and 2/3 of the patients were taking more than 5 medication. If we compare the efficacy of Rivaroxaban compared to Warfarin in the Rocket AF study, the elderly population had a much higher benefit compared to people below the age of 75 years. The absolute risk reduction was 1.5% in the people above the age of 75 years, while in the younger population, the absolute benefit was 0.7%. So it was twofold absolute risk reduction in the elderly population compared to the younger population. The major events were the all-cause mortality, non-hemorrhagic stroke, and life-threatening bleed. We know that the most of the bleeding happens in people above the age of 75 years. 75% of the bleed happens in people above the age of 75 years. And this was exactly the same what was seen in the Rocket AF study also. One of the criticism for the Rocket AF study is that there was a proportionately higher bleed in the Rocket AF study compared to the other studies like the Aristotle or the Relay. But if you look at the real world data of Rivaroxaban, the Sanders study, which had the chart score of say around 2 compared to the Aristotle and the Relay study, the bleeding risk was also exactly the same. There is no dose reduction required for NOAC for age alone, except for dabigatran. Dabigatran over the age of 80 years needs a dose reduction. Over the age of 80 years, the dose advice is 110 milligram twice daily. Those between the age of 75 to 80, with a higher bleeding risk, the dose has to be reduced to 110 twice daily. While for Apixaban, we need to reduce the dose just not on the age alone. Those with renal impairment and weight less than 60 kilo needs dose adjustment. The advised dose is 2.5 milligram twice daily. This is from the real world data. It has been shown that Rivaroxaban reduced the risk of stroke versus Warfarin without increasing the risk of major bleeding in frail patients. Here we can see that the Rivaroxaban had a significant reduction in stroke. The hazard ratio is 0.68. There's a 32% reduction in stroke. The major bleeding was neutral. The intracerebral hemorrhage was decreased by nearly 50%. While for Apixaban, you can see that the hemorrhagic stroke was higher in the frail individuals. The stroke was decreased by 22%. The bleeding was almost neutral. So, Rivaroxaban is the only agent which does not require a dose adjustment based on age or weight. Dabigatran, we have already seen that people above the age of 80 years needs dose adjustment. The dose advice is 110 milligram twice daily. Those between the age of 75 to 80 also needs dose adjustment if they fall into the high risk category. Apixaban needs dose adjustment if two of the three are present. Those are age above 80, weight below 60, or the creatinine is above 1.5. The two of the three are present, then need a dose adjustment. The dose is 2.5 milligram twice daily. Rivaroxaban needs dose reduction if the weight is below 60 kilogram. So Rivaroxaban is the only agent which does not need a dose reduction depending upon the age or the weight. This was one of the real world data, the Coleman-Sierra study, which looked at the effectiveness of warfarin versus Rivaroxaban in patients, the elderly population above the age of 80 years. More than half of the patients with atrial fibrillation are above the age of 80 years. But in our outcome trials, these are underrepresented because the outcome trials have strict inclusion criteria and exclusion criteria. The extremes of age, multiple comorbidities are usually excluded from the study. This is again from the US market scans claims database. They identified 4,400 patients who were taking Xarelto. The 1:1 propensity score matched to warfarin, analyzed the primary effectiveness outcome as well as the safety outcome. And it was found that Rivaroxaban significantly decreases stroke and systemic embolism. There was a nearly a 40% reduction in stroke and systemic embolism. The hazard ratio was 0.61. Ischemic stroke was decreased by 41%. Both were statistically significant. There was a numerical reduction in hemorrhagic stroke, intracerebral hemorrhage, and major bleeding. Hemorrhagic stroke was decreased by nearly 40%, and intracerebral hemorrhage was decreased by 43%. Stroke, systemic embolism, and ischemic stroke were statistically significant, while the bleeding risk was numerically less. This is yet another real world data, the Saphir-AC study. Here again, it was found that the major bleeding was decreased by 47%, intracerebral hemorrhage by 62%. Both were statistically significant. You can see the p-value 0.001 for the major bleeding. Stroke was decreased by 38%, mortality by 19%. Two-thirds of our atrial fibrillation patients have renal impairment. If the patients have renal impairment, the stroke is higher, mortality is more, and the bleeding events are higher. And if these patients are treated with warfarin, it has been found that there is a faster decline in renal function compared to those not exposed to warfarin. Both the chronic kidney disease and acute kidney injury are more in warfarin treated patients. This is in the ROCKET-AF study. We can see that the critical organ bleeding, intracerebral hemorrhage, and fatal bleeding, all of them are higher in the warfarin treated patients. The critical organ bleeding was 45% less in Rivaroxaban treated patients. Intracerebral hemorrhage was 19% less, and the fatal bleeding, it was almost 60% less in Rivaroxaban treated patients compared to warfarin. Here you can see again that the patients exposed to warfarin compared to those not treated with warfarin. The left one is the decline in EGFR. By the end of 5 years, the EGFR was significantly lower in warfarin treated patients. And right is the vascular calcification. The vascular calcification was significantly more in warfarin treated patients. CKD patients by themselves, the vascular calcification is higher. But if the CKD patients are treated with warfarin, their chance of vascular calcification significantly goes up, because the carboxylated MGP is the one which inhibits the vessel calcification, and this needs vitamin K for carboxylation. So when the patients are treated with warfarin, the active MGP is less, and thereby the vessel calcification significantly increases. The reloaded is another real world data in which they compared the NOAC versus fenfluramine, which is not available in UAE. A couple of my patients were taken from Germany. They were getting it from Germany. It was available as Marcumar. In the analysis of the reloaded study, they found that those treated with Rivaroxaban had a significant reduction in end-stage renal disease. The hazard ratio is 0.27, almost a 73% reduction in end-stage renal disease. Acute kidney injury was decreased by 23%. But if you take Apixaban, end-stage renal disease was lowered in Apixaban also, while the acute kidney injury was almost the same. If you look at these elderly patients with diabetes, again with Rivaroxaban, there was a 68% reduction in the chronic kidney disease. Acute kidney injury was decreased by 28%. Both of them are statistically significant. While for Apixaban, only the end-stage renal disease was lowered. End-stage renal disease was lowered by 40%. If you take the acute kidney injury, actually it is on the wrong side. It was favoring vitamin K antagonists. So in 2019 AHA-ACC guideline, they mentioned that NOACs, particularly dabigatran and Rivaroxaban, may be associated with lower risk of adverse renal outcomes than warfarin in patients treated with AF. This you have already seen. If you take a look at the adherence to treatment, Rivaroxaban being once daily, the adherence to treatment is the best. Generally, the once daily treatment, the patient takes it regularly, and very rarely they make a mistake of going for twice daily. While patients, the medicines in which we give twice daily, quite often they'll end up taking once daily only. 30% of the patients with dabigatran and Apixaban were taking the medicine once daily, making it less effective. This could be one reason why in the real world data, often we see Rivaroxaban more effective than the other NOACs like dabigatran and Apixaban, which are given twice daily. Maybe because the adherence to Rivaroxaban could be better in the real world data. While in the outcome trials, these patients are meticulously followed up. They are very closely followed up, frequent phone call, and make sure that the patient takes the medicines correctly. But when it comes to real world data, quite often we find that Rivaroxaban is more effective. One of the reasons maybe the adherence is much better with Rivaroxaban compared to dabigatran and Apixaban. Both of them are advised twice daily. And as was seen in the real world data, in 30% of the time, they end up taking it only once daily. This was one of the studies in which the Rivaroxaban was compared to warfarin in patients with stage 4 and 5 chronic kidney disease. This is an off-label indication at the moment. Those with stage 5 CKD, Rivaroxaban as per any guideline is not indicated. At the moment, the preferred treatment is warfarin. In the 2019 ACC-AHA guideline, based on a retrospective analysis, the lower dose of Apixaban was recommended for stage 4, stage 5 CKD along with warfarin. And this is just based on a retrospective analysis of one of the studies. In this study, when the Rivaroxaban was compared to warfarin, in patients with stage 4 and stage 5 CKD. Both the group had the Rivaroxaban group, there were 780 patients, Warfarin 1,500 patients. And the average CHA2DS score was 4.5, S blood 3.5, and most of the patients were stage 4 CKD. Stage 4 CKD is the EGFR between 15 and 30. 15% of the patients were stage 5 on dialysis, 4% patients stage 5 without dialysis. It is found that Warfarin was Rivaroxaban was as effective as Warfarin in decreasing the stroke. And as far as the bleeding is concerned, Rivaroxaban was a shade better. The event-free survival was better with Rivaroxaban compared to Warfarin. This was another study in which the Rivaroxaban was compared to Apixaban in patients with stage 4 and stage 5 CKD. The background was that as per the current ACC/AHA recommendation, stage 4, stage 5 CKD, currently the advised treatment is Warfarin. Apixaban has also been advised based on a single retrospective database analysis. The objective of the study was to compare Rivaroxaban versus Apixaban in patients with AF and end-stage renal disease undergoing dialysis, and stroke and systemic embolism and major bleeding. So almost equal with both Rivaroxaban and Apixaban. There was no significant difference in the effectiveness and safety of Rivaroxaban compared with Apixaban in patients with AF and end-stage renal disease requiring dialysis. So in our patient, Mr. Amin, who is 76 years old, he has atrial fibrillation, diabetes, and stage 3 CKD. Using Rivaroxaban, we have found that significantly decreases stroke compared to Warfarin. It is a preserving renal function as was seen in the real world data. We have seen that the renal function decline was much faster with Warfarin compared to Rivaroxaban, and comparing Apixaban to Rivaroxaban. Rivaroxaban decreased both the end-stage renal disease and acute kidney injury, while Apixaban lowered only the end-stage renal disease. And in the ROCKET-AF study compared to Warfarin, the fatal bleeding was decreased by almost 61% with Rivaroxaban in the elderly population with renal impairment. Definitely there was a significant reduction in stroke and systemic embolism. There was a decrease in cardiovascular death. And there's one dose adjustment. Below 50 EGFR, need to go for 15 milligram. And we can optimize dose pretty easily. There is no need for dose reduction based on age or weight. And adherence is the best with Rivaroxaban, being once daily. So our patient, Amin, with a high-risk patient having diabetes, stage 3 CKD, over the age of 75 years, with the available data, Rivaroxaban is one of the best choice for him. Of course, he can, any NOAC is better than Warfarin in many aspects. Significant reduction in cerebral hemorrhage compared to Warfarin for all the NOACs. All of them are at least as effective as Warfarin, and ease of use. And those of us, we are using Warfarin for our prosthetic valve patients, and we find it extremely difficult to keep the INR in the desired range. A lot of drug-to-drug interaction, direct-to-food interaction, a lot of variability in many patients. The ease of administration makes it extremely easy. For Rivaroxaban being once daily, the adherence is much better. And one thing which stands out is intracerebral hemorrhage is more than 50% less in NOACs compared to Warfarin. So when it comes to the high-risk patients, ROCKET-AF is the study in which high-risk patients were studied. While for Aristotle with Apixaban and Relay with dabigatran, the average CHA2DS score was 2. While Rivaroxaban, the ROCKET-AF had really high-risk patients. Nearly 45% of the patients were above the age of 75. 40% of the patients were diabetic, 60% heart failure. and the average chart score was 3.5. So if you go by the real evidence, the NOAC with the evidence in high-risk patient is Rivaroxaban. Thank you. Thank you so much for the patient hearing. We'll be happy to take on suggestions or questions.
Thank you very much, Dr. Joseph. Now I would like to start the panel discussion. I can see we have a lot of questions from audience, a lot of questions on triple therapy that for a patient who has high risk of bleeding and you are going to start triple therapy, how long you will continue with triple therapy, and then when you will shift to double therapy. I think Dr. Muhammad, you mentioned this in your presentation. So if you don't mind, you can start.
Exactly, Dr. Nasheen. So it depends if the patient at high risk of bleeding, very, very high risk of bleeding. If the patient at high risk of bleeding, he can be on triple therapy for 1 month, then he can carry on dual therapy for 12 months, and then can be only on NOAC. If the patient, like the patient I presented, is an extremely high risk for bleeding, we can start by dual therapy from the beginning, NOAC and clopidogrel for 1 year, and then we put him on NOAC.
Extreme high risk, even 6 months of clopidogrel plus extreme high risk of bleeding, maybe with the reason, I mean, you may even stop short at 6 months, and subsequently the NOAC alone could be continued. Yeah, 1 year is the generally advice.
Yeah. Thank you. Then there was a question on combination of NOAC or Rivaroxaban with Belenta. Do you have any experience with that, or with the dual therapy always you prescribe Rivaroxaban or other NOACs and Plavix?
This is for Dr. Joseph or me?
For three of us.
I think we have a limited experience with TIGA, but in some of the trials, the TIGA was included, I believe. I'm not sure exactly with the number. Maybe Dr. Joseph can refresh my mind. I think it was like 10 to 15% in the Augustus trial. The patient received the ticagrelor. Still, it's not like a first option that we give NOACs with ticagrelor because of the limited experience. But we have some patients, especially who developed some in-stent restenosis, and we found that they have clopidogrel resistant and shifted to ticagrelor, and we didn't suffer any major complication. What do you think, Dr. Joseph, about this?
As you rightly said, we don't have too much of experience with the NOACs and ticagrelor compared to clopidogrel. But as an antiplatelet agent, definitely ticagrelor is superior to clopidogrel, as was seen in the Plato study. And the stent thrombosis was less, mortality was less, free event was less. Because most of the studies with the NOACs were conducted with clopidogrel. So if you truly go by the evidence base, we have limited data on ticagrelor and NOAC.
We have less than 10% experience.
Yeah.
Yes, in our experience also, we commonly combine Plavix with NOAC, but only if there are special cases, as Dr. Muhammad also said, then we have some cases whom we prescribe NOAC and Belenta, the combination. Now, still in the combination chapter, is one of the question was what dose of Rivaroxaban you prescribe when you want to combine it with Plavix in the dual combination? Is it 15 milligram or 20 milligram?
I think this will be according to the reference in the guidelines and the Pioneer study. So the Pioneer study, they used 10 and 15 milligrams. So 10 milligram if the patient had renal impairment, and 15 milligrams if there is no renal impairment. The design of the study, they had 3 groups. One was Warfarin with dual antiplatelet. Second group, 2.5 Riva with single antiplatelet, and 10 and 15 milligram with single antiplatelet. So it's mentioned clearly in the guidelines 15 milligrams unless the patient needs a reduced dose of 10 milligrams. But
2.5 was with dual antiplatelet.
Or was the 15 milligrams, not the 10 milligrams.
2.5 milligram BD was with dual antiplatelet.
Yeah, exactly.
It was dual anti, not with single anti, with dual antiplatelets. And similar dose was used in the acute coronary syndrome in the ATLAS study, I think. They had a previous study, not in atrial fibrillation patients. Yeah, ATLAS study where the dual antiplatelet with the vascular dose of Rivaroxaban had shown to have a significant decrease in vascular events, actually. But this was not seen with the dabigatran and apixaban in the similar studies which were conducted for acute coronary syndrome. Not in the context of atrial fibrillation. For acute coronary syndrome, they had the 2.5 BD of Rivaroxaban with dual antiplatelet, and the bleeding risk was not significantly increased. And the acute coronary events were significantly lowered. Prior to the COMPASS study was for stable patients. The ATLAS study was for the acute coronary syndrome patients. Non-AF.
Yeah, this trial is something else. This is
yeah, exactly. I said it is not for AF patients. So they had the Pioneer study. The 2.5 milligram was with dual antiplatelet, while 15 milligram was with the single antiplatelet.
Yeah, but we want everyone to forget about the 2.5 for now, whether for the COMPASS or the Pioneer. It's either 15 milligram, the dose, 15 milligram with clopidogrel, or 10 milligram as a reduced dose, and whenever it's indicated as a reduced dose.
Yes. This is the dual therapy for patients that need antiplatelet and they have atrial fibrillation. So either Rivaroxaban 10 milligram or Rivaroxaban 15 milligram. Now, another question is about diabetic retinopathy. One of our colleagues mentioned that despite of the observation with apixaban, still there are patients who are on apixaban and they have severe diabetic retinopathy. And he again wanted to ask, what would be your recommendation for anticoagulation for patients who have severe diabetic retinopathy?
We cannot risk specify on only one parameter. We need to know everything because, as I mentioned, the patient is like one package. So we need to know the comorbidities, the other risk factors, the renal functions. But in general, when I have multiple comorbidities in a patient, as you mentioned, with severe diabetic retinopathy, severe grade advanced diabetic retinopathy, or he suffered any vitreous hemorrhage or any bleeding, I will not prescribe for him apixaban. I can use other alternatives.
Dr. Joseph, you want to add to that, or you are okay with that? Yeah, I agree, Dr. Mohammed. Yeah, exactly.
Then there is a question on patients that you want to take him to cath lab, and the patient is already on NOAC. So do you actually stop NOAC at the time of PCI?
I will let Dr. Joseph answer the question for the PCI, and I will tell you what I do in ablation. In ablation, we have all the trials with NOAC. We don't stop the NOAC. We take the patient, take him to the cath lab. And by the way, ablation is a very complex procedure. We do several puncture, we do transeptal puncture, we do mapping in the left atrium, and we don't stop the NOAC. And this is a question that I always ask the guidelines and our interventionists, because I know they stop NOAC 24 hours for elective procedure, but of course, if the patient came with acute coronary syndrome, acute MI, they would take the patient to the cath lab. But I'm not sure why for elective procedure, coronary angiography, we have a recommendation to stop NOAC 24 hours. On the other hand, for a complex AFib procedures, we have a recommendation not to stop NOAC. Any input, Dr. Nushin or Dr. Joseph, for this?
And generally, for coronary intervention, people prefer the time-tested, which has been in the, we've been using it for quite a long time. So only thing is that for acute coronary, if the patient had the recent dose of the NOAC, giving an additional dose could have a significantly increase. Otherwise, if the patient has already passed the 12-hour period or near to the 12-hour period, is already in the half-life is already over. So using the standard protocol of Warfarin or Enoxapan is not going to affect the. But generally, the Enoxapan or Warfarin is used for the, sorry, not heparin or Enoxapan is used for intervention for coronary rather than continuing on NOAC.
At least for the when we do AFib ablation, we keep the ACT above 350. So we keep ACT above 350, and we are doing, as I mentioned, transeptal puncture complex procedure. But we don't. The recommendation in the past was to stop it for 24 hours or 2 hours. But over the last 3 years, the guidelines changed. For uninterrupted, we have from the Riva trial, we have from the Ligatran trial, Apixaban trial, and the recommendation not to stop it. But the practice I know now, if it's an elective procedure, to stop it 24 hours before the procedure. But if acute coronary syndrome, acute MI, you don't have option. You have to take
Actually, the factor Xa inhibitor, the mechanism is even if it is injectable or oral, it's almost the same. And even for the DVT and pulmonary embolism, also the oral anticoagulants can be, like the NOACs, can be given directly. So probably, surely there will be a stage in which people will be doing it with NOAC. But at the time, at this point of time, they are much more confident in doing with the time-tested medicines, which are the heparin or the enoxaparin.
But from your experience, like if you took a patient with primary PCI and acute myocardial infarction, you took it to the cath lab on NOAC, did you face any major problems?
No, most of the cases which are done here, they don't face any major problem basically, but then it is done with the heparin. Most of the time it is done with heparin.
Okay, thank you.
Yeah, so let's say that the EP lab, they are more brave, braver than the cardiac catheterization lab. And perhaps, as Dr. Muhammad said, after 1 year, we may join your protocol and we do the procedure while the patients are on NOAC. Now,
the trial showed the opposite. Showed if we stop NOAC before the procedure, the patient might suffer silent infarctions and embolic stroke. That's why the paradigm shifted towards not stopping the NOAC before the procedure.
Now, there is another question that is it safe to change the NOAC from one NOAC to another for a patient? Is it safe if a patient is on Apixaban and you want to shift the patient to Rivaroxaban? So the safety issue here, is it safe?
If there is a reason for the shift, first we have to check why we are shifting and review our case. And after we reach the consensus that it's indicated for shifting, it's safe, we can do it. And the recommendation, we can begin the other agent by the time of the second dose of the medication. This is how we do it. We don't just start it right away. We have to wait for the time of the second dose, and we can start by the second dose time.
Dr. Joseph, the same?
Yeah, definitely. I mean, if the patient is on Rivaroxaban once daily, when the next after 24 hours, when the next due dose, if there is an indication to stop it. Some patients may say, I don't want twice daily, I like to shift to a once daily dose, once daily medicine. So in that way, we have shifted many patients to Rivaroxaban because patient himself say, I don't want twice daily. And there are other indications, like suppose the patient is on dabigatran, developed a GI bleed, and if you want to give something else which does not produce that much, then we may go to a safer one. So, and as Dr. has already mentioned, we wait for the next due dose of the drug, and at that point of time, we switch over to the other one.
So, as I ran the anticoagulation clinic as well, shifting is safe, providing that you have checked the renal function and all the indication, and there is a reason for shifting. We have to be very careful that both patients and a lot of time elderly patient, the family or caregiver, they are aware that, for example, Apixaban is stopped and the Rivaroxaban is started, not to have both. And the same thing goes when you want to shift from Warfarin to Rivaroxaban, that the patient should know that Warfarin has to be stopped, and these are the two anticoagulants that they work very similarly. So that the patient's education is very important. Now, Dr. Muhammad, left atrium appendage closure. Do you continue this is my question. Do you continue anticoagulation or you stop it?
No, now all the trials that we are having, this was a tradition in the past, like with the first generation of the Watchman device, that once you put the device, you continue for 45 days, anticoagulation, then you continue on antiplatelet. Now with the aspirin Plavix feasibility trials done in the new appendage occlusion device, like the Watchman Flex device and the Amin and Platza device, we stop anticoagulation right away. We don't need to give anticoagulation. We give antiplatelets.
Lifelong, yeah?
6 months, again, according to the patient risk, minimum is 6 months. and up to 1 year.
All right. Now, again, this is my comment and a question that I want your opinion about it. We always talk about subtherapeutic dosage of the patients with atrial fibrillation with renal impairment. And we three of us, we know how commonly other NOAC at the lower dose are prescribed for a patient, elderly patient who has little bit of renal impairment and atrial fibrillation, just to be at the safe side of the bleeding. So it is commonly practiced. But I always tell buyer, actually, it's not the issue of the doctor's prescription to be at the safe side, prescribing a lower dose of anticoagulation for elderly patients with renal impairment. Is actually a company like Bayer who have so many studies, and Dr. Muhammad, you mentioned about Daliper study, which is a very major and a big study of a patients, diabetic patients with chronic kidney disease stage 3 and 4. And definitely there was a benefit with Rivaroxaban. So I think the company themselves, they did not promote Rivaroxaban as an agent that can be safely used in a patient with renal impairment. Although they had several studies, and both of you actually mentioned these studies, that not only it can be used safely, but also it can prevent further deterioration of the kidney function for this population. So I want your opinion about this, please.
I think the only issue that the number of cases of patients in the studies was not quite big enough. Like the reduced dose that we are using for apixaban from the Augustus trial, this dose came from only 400 patients. So this is not a big number to judge the safety and reliability of the medication. But when you look at the American guidelines, they wrote it clearly that you use warfarin for patients with end-stage renal disease, but you may consider NOAC, and they wrote apixaban. On the other hand, the same results with the renal protection with apixaban, the same like Riva. I'm not sure why they wrote only apixaban, not apixaban and Riva. But at the end of the day, they wrote it in the guidelines, you may consider. If you did analysis, you will be more shocked that this terminology, you may consider, came only from 8 cases, 8 patients, only 8 patients in the subgroup analysis of the study. They wrote, you may consider an end-stage renal disease. So I think we need more trials, we need more studies. I know that they had one big trial called Renal AFib trial. It was started in 2018 and was aborted by the mid-2019. And we don't have any news why it was aborted, but I can assume we didn't have a major good result to carry on with this study. I think we need more studies, more trials related to this, more randomization, and we can reach a consensus. I know that we showed some of the studies, but I think we need more, because if you want to change the guidelines, you cannot change it by 1 or 2. You need more global studies so you can reach a consensus.
Dr. Joseph?
I agree with that. We need to have large studies to have a clear-cut indication as per the guideline. These are all the studies what we have, the smaller studies and retrospective analysis. So to be included in the guideline, definitely we need large studies. But the point is, from this retrospective analysis and the smaller studies shows that these agents are as safe as warfarin. Both apixaban and rivaroxaban, in whatever the studies we presented, they were as safe as warfarin and as effective also. Warfarin, we know that it tends to have a further decline in renal function. EGFR decline was much more with warfarin compared to NOAC. So once we have larger studies, definitely the guidelines will change in future. And whatever studies available today shows that the rivaroxaban and apixaban could be used in patients with stage 4 and even end-stage renal disease also. But the guidelines we have larger studies.
Dr. Joseph, What's shocking me that I know the gold standard was warfarin.
Yes.
And while you were talking now, you were saying as protective as warfarin and as safe as warfarin. I think if we had NOAC at the beginning, warfarin will not pass stage 1 approval.
Definitely. But then when you want to change a guideline, what is there in the guideline? You need to
but
have.
I'm not sure. This is very funny for me because I think warfarin should be abundant as a practice, and it should be removed even from the guidelines, except for special category of patients for the time being with valvular heart disease.
Prosthetic valve.
Prosthetic valve. As I told you, 4 days ago, publication in the JACC for valvular AFib bioprosthesis.
Yes. Only metallic prosthesis. Probably the metallic prosthesis is metal, maybe mechanistically may need multiple factors.
There's a publication from Korea, but it was insurance observation 3 years ago on metallic valve, but it was not that much randomized. Of course, it was retrospective. I think it was from the Korean group in one of the major hospitals, 5,000 cases. But as you said, we need more randomization, more studies. But I think keeping warfarin as a punch bag should be stopped. I know we will never have head-to-head trials with all the NOACs. This will not happen. But I think we reach a conclusion. I think over 200 physicians listening to us now, I think they agree 100% that warfarin is not the way to go, especially in renal patients with renal disease. By the way, during my residency and during my fellowship, most patients that bled, they are the renal patient with renal disease on warfarin. And most of the cases that I did appendage occlusion for them, they are renal patients with renal dialysis and atrial fibrillation. Either they are having stroke when they stop warfarin, or they are having bleeding when they take warfarin. So that's why I think all of this will change soon.
For metallic prosthetic valve, there was a study with dabigatran. Despite using the higher dose of dabigatran for 225 milligram, the stuck valve was more. So the metallic prosthetic valve, I don't know whether other companies are going ahead with, because of the failed study with dabigatran, they say that mechanistically, maybe the metallic valve, the clot formation, you need to block multiple factors, while the NOACs just block one factor. I mean, this was.
They had some trials as well, I believe, with the aortic valve, and it didn't show good result at that time as well. This like 6 years ago or 5 years ago.
Yes.
Dear colleagues, this is a live presentation from UAE, talking to you about patients with atrial fibrillation and Rivaroxaban, especially high-risk patients, diabetic patients with renal impairment and elderly patients, high-risk patients that you may hesitate to start anticoagulation for the prevention of the thromboembolic manifestation of atrial fibrillation. But with the extensive experience that we have built up during so many years of prescribing NOAC and Rivaroxaban, and to the degree that we have various indications for the prescription of Rivaroxaban in the treatment of atrial fibrillation, in the treatment of pulmonary embolism, as Dr. Joseph mentioned, in the treatment of the acute coronary syndrome, and also recently, as Dr. Muhammad mentioned, in the treatment of the patients with the bioprosthetic valve and atrial fibrillation. So all of this experience and all of this hands-on experience with the agent can give you more and more reassurance that the agent you are prescribing is safe. Even the question of the antidote or no antidote is no longer an issue here. We are more confident to prescribe the right medications for the right patients. Now, for this study of the bioprosthetic, we had a question from our audience. And the question was that in the bioprosthetic valve, anyway, we don't need warfarin. But if the patient is in atrial fibrillation, then definitely, like any other atrial fibrillation, NOAC can be prescribed. So in our colleagues' opinion, this is not something new that NOAC would work in this kind of cases. Do you have any comment for that?
Yeah, but again, NOACs were prescribed only in non-valvular atrial fibrillation. So this is opening another spectrum. This is considered as valvular AFib, not valvular AFib. So the entity, the patient itself, it changed. What is the difference between valvular and non-valvular AFib? The site and location of thrombus. In non-valvular AFib, the site of thrombus accumulation lies 90%, and even in one of the recent study, 99% inside the left atrial appendage. But valvular AFib, the mechanism is different. You can have thrombus formation everywhere, in the left atrium, on the valve, in the appendage, and the appendage will only contribute by 40 to 50%. So if you are opening a new entity of valvular AFib, the idea is not about the valve, by the way. The idea is not about being bioprosthetic valve or else. The idea here is about, we are talking about valvular atrial fibrillation in those patients, about the mechanism of thrombus formation. I'm not talking about the valve per se, the type of valve. I'm talking about the mechanism of thrombus formation. So if the medication is effective to prevent the thrombus formation beside the left atrial appendage and elsewhere on the valve or in the left atrium, I think this is an advancement, but still we need more studies, because one study, it's not enough. We need more study, more global study in order to have more confidence in this. But for sure, it's a step forward.
Yeah, I may add to that a lot of these patients with the bioprosthetic wall, maybe also, I think in the study it was mentioned that they had the severe MS also. So as you said, the mechanism of the disease itself is different. So that's why, although there are colleagues that have prescribed this off-label of a patient who had bioprosthetic valve and also had atrial fibrillation, and they were prescribed NOAC without having any study on off-label, because as you gain a trust for an agent, you sometimes, if you are senior enough, you actually prescribe medication as off-label. Dr. Joseph, you want to make any comment on this study? Anything to add?
Yes, definitely this is a step forward, and actually there should not be any reason why the NOAC should not be effective in a valvular AF. So VAL-AF at the moment is restricted to those with severe mitral stenosis, moderate or severe mitral stenosis. So those with aortic valve disease or mild mitral regurgitation or MVP, and those things are not included in the valvular AF. So valvular AF is those with significant mitral stenosis. And I mean, mechanistically, there should not be any reason why the NOAC, if it is effective for the deep vein thrombosis, the LA appendage clot, and for pulmonary embolism, in all the scenarios, if it is effective, why it shouldn't be effective for when preventing clot formation in the LA also? It should be equally effective. But we need to have studies to get into the guideline and have to have the confidence. Definitely, it should be effective.
Yes, thank you very much, Dr. Joseph. I think we have reached to the end of tonight's webinar. At the end, I would like to ask both of our speakers to make a very short summary and take-home message for their presentations. But before they start, I would like to conclude and telling our colleagues at the webinar that although all NOACs are very safe in the management of atrial fibrillation, but there are some difference between different classes of NOAC that can be prescribed safely in a patient who is counted as high-risk patient among patients with atrial fibrillation. Patients who are elderly, patients who are diabetic, and patients who have renal disease. And all you should do is you go back to the major studies that has been done with these agents and see the characteristic of the patients that were included and patients who were followed up for more than 3 years. And you can see that a lot of those patients in these major trials are actually matching with the high-risk patients that you see in your clinical practice. We heard it from expert opinion from consultant EP who deals with patients with atrial fibrillation. We heard it from our senior consultant cardiologist who deals with all kinds of patients with atrial fibrillation. And you heard it from me who runs the anticoagulation clinic for so many years, and I have experience of the side effects and also the benefit of the patients that they get from this agent. Now, the last take-home message by our speakers. Dr. Muhammad, please.
Actually, Dr. Nishin, you put it nicely. You put everything in the few words that you just mentioned. Having multiple NOACs with multiple options and multiple mechanisms and multiple excretions, this is a good variety, but we have to choose the proper NOAC for the proper patient. And by doing so, I think we have to think loud. So it's not uncommon. We speak as a colleagues to discuss cases like round table discussion, not like single decision. We can discuss, especially in highly morbid cases. We can discuss one of the cases I was consulted yesterday, 89-year-old lady, her body weight is 65, and she, they discovered at the hospital that she had atrial fibrillation. She was not on anticoagulation, but she came with GIT bleeding and hemoglobin of 7. So just imagine, once we have a round table discussion, we can reach the proper management for our patients, and we can highlight, of course, the guidelines. And we have to keep in mind, we cannot manage all patients 100%, because in the NICE guidelines, they mentioned some of the cases, you have to see the cost benefit of the management. Some of the cases, if you have very, very high risk of bleeding, and you still have high risk of stroke, you have to speak with the family, and it's written in the NICE guidelines neatly. You have to have a round table discussion with the family and to explain for them the risk of anticoagulation and the risk of not giving the anticoagulation, and they have the right to choose not to have the anticoagulation. So this is very important to discuss with the family, to involve the patient, to, as Dr. Joseph mentioned, to consider the patient preference as well according to the medication he's taking. So this is very important while prescribing the medication, and more importantly, the follow-up. It's not just writing the medication. Follow-up of the patient after 3 months and 6 months, because the patient is a dynamic process. And luckily with the NOACs that we are having now, we are prescribing all the NOACs, and we don't have major bleedings that's like making us less confident or feel any worries.
Thank you. Dr. Joseph?
Yes, I mean, regarding all the NOACs are at least as effective or even better than Warfarin. So there is no confusion in that. But then if you look at the high-risk patients, ROCADIF is the study which had really high-risk patients. Nearly half of them were above the age of 75 years, 60% had heart failure, 40% had diabetes. The average CHART score was 3.5. So in a high-risk patient, if you truly go by evidence, at the moment the evidence is with Rivaroxaban, because they included patients who are really high risk. And the use of once daily makes it a little attractive than the other ones. So as such, all the NOACs are better than Warfarin, and we have to individualize as per the patient choice. And for the higher risk patients, which we get the evidence from the ROCADIF study, probably we have Rivaroxaban as an edge over the other ones, but all of them are equally effective. Thank you.
Thank you very much. I would like to thank both of you, Dr. Muhammad and Dr. Joseph, for the excellent presentation and excellent sharing your cases and your experience in the question and answer session. I also like to thank all of your audience who stayed until now, listened to you, and also asked their questions and shared their concerns about the therapy of Rivaroxaban in the management of atrial fibrillation. With that, I would like to wish you a very nice evening and a safe life in these days, and I hope to see you soon. Thank you very much.
Thank you.
Thank you. Thank you.